Thank you for the opportunity to present our work today. We will be presenting and describing subgroup differences based on race, BMI, and age in the clinical outcomes among women receiving CAB, rilpivirine long-acting in the OPERA cohort. These are my disclosures. We know that CAB, rilpivirine long-acting is the first complete long-acting injectable antiretroviral regimen for the treatment of HIV-1. It was approved by the FDA in January 2021, and the regimen involves a pair of injections that can be given either every month or every 2 months. It is indicated for virally suppressed individuals who are already on a stable antiretroviral regimen. CAB, rilpivirine long-acting has many advantages which present itself as an option, a good option for therapy for women with HIV who represent more than 50% of people with HIV worldwide. The potential advantages include convenience. Obviously, we can reduce some of the psychosocial concerns that we have surrounding stigma, surrounding disclosure, and we can minimize disruption of daily responsibilities. The fact that it is a set of injections given every month or every 2 months already outside the home or outside of the workplace makes it much easier for those women struggling with daily oral therapy. We describe the differences in terms of clinical outcomes, persistence, adherence, virological effectiveness among women receiving CAB, rilpivirine LA, and we stratified by race, BMI, and age. I do want to point out that we did share some data at CROI 2025, and that was in the group of women who initiated CAB, rilpivirine with viral loads under 50 copies per ml. Here in this study, we are including all women, regardless of the viral load at initiation for CAB, rilpivirine. We used the data from the OPERA cohort. For those unfamiliar with this is a longitudinal cohort in the United States. It is a database that prospectively captures electronic health data in 101 clinics across 23 states and territories in the United States. At the time of the study, there were over 150,000 people with HIV in the OPERA cohort, and roughly it represented 14% of people with HIV in the US and 11% of women with HIV in the US. In terms of our study design, the study included cisgender and transgender women living with HIV. They were 18 years of age or older. They were on a stable antiretroviral regimen. They had received at least one CAB, rilpivirine injection from January 2021 through August 2023, and they could not have participated in a CAB, rilpivirine long-acting clinical trial. Also, it included women, as mentioned before, with all viral loads at initiation, including those above 50 copies per ml. The women were followed up until one of the first of the following happened, whether it was regimen discontinuation, loss of follow-up, death, or study end at on the date of February 29th, 2024. We looked at a couple of outcomes. The complete initiation is defined as giving the first pair of, the first 2 sets of injections within 67 days. Persistence was measured in terms of how much time women were on the regimen in terms of month, and they had to be on the regimen at the study end. In terms of adherence, this was based on the timing of the injections, based on the days after the last injection given, and you can see they're categorized as on-time injections, delayed injections, or missed. And again, you can see the number of days. It would depend on if they were on every month dosing or every 2-month dosing. Discontinuation was more than 67 days or more than 127 days since the last injection. Virologic suppression was defined as either maintaining a viral load less than 50 or achieving a viral load less than 50 in those that were above 50 at initiation. Among women who had a viral load less than 50 copies per ml at initiation, you could see that viral load was assessed at every follow-up visit and at the last follow-up visit. However, among women with viral loads greater than 50 copies per ml at initiation, viral load was assessed at any point during the follow-up and at the last follow-up. Confirmed virologic failure was defined as 2 consecutive viral loads that were 200 copies per ml or above, or 1 viral load of 100 copies, greater than 200 copies per ml, followed by discontinuation within 2 months if the woman was on a Q1 month dosing, or discontinuation within 4 months if she was on a Q2 month dosing. Results. So to get a better understanding of how the cohort was looked at, we see that there were 150,940 people with HIV in the OPERA cohort at the time of the study, of which 2,759 received CAB+RPV long-acting injections, of which 532 were women. And then this was stratified and looked at in terms of race, BMI, age. About 2/3 of those women were Black, and about half of them had a BMI of 30 or above, and almost 2/3 of them were less than 50 years of age. The demographic characteristics at initiation of these injections. You can see here that in terms of the race, Black women tended to be single, lived in the southern US. They also had a higher BMI. Those who were non-Black, 44% were Hispanic. And in terms of BMI, in terms of transgender women, they had a lower BMI and they were less than 50 years of age. Across the board, most of the women tended to be single and reside in the southern US, where we have the highest impact of the HIV epidemic in the United States. The clinical characteristics, this table illustrates, again, when you see the orange boxes, this is a descriptive analysis, just focusing more on the clinically meaningful points. And you can see that Black women had a higher BMI, and they tended to start CAB+RPV injections at a higher viral load, meaning greater than 50 copies per ml. And the VAX mortality score, this is an index that we use in the United States to predict mortality or in the next 5 years, was higher. Not surprisingly, in those who were over 50, the VAX mortality score was also higher. When we look at that second initiation injection across the subgroups, we can see that in the Black population of women, 16% versus 6% in the received that second initiation injection of CAB+RPV 53 to 67 days after the first injection, meaning that they missed their window. The other numbers in the other subgroups were quite similar. And in terms of persistence among women who did complete their initiation, roughly they were on the regimen for about approximately 12 months across the subgroups. If we focus on the orange box within the race subgroup, we can see that Black women actually had a lower rate of discontinuation versus non-Black women. When it came to looking at persistence with the maintenance injections, or I'm sorry, adherence with the maintenance injections, among women who had received at least one maintenance injection, we can see that the numbers are quite similar, and most women had their maintenance injections on time. So overall, 57% of women had maintenance injections on time, and those that were late, 60% only had one late injection. So it means that they were not recurrently late in their maintenance injections. Now, virologic suppression, you're going to see 2 slides in 2 groups. This is the first one among women who initiated with a viral load less than 50 copies per ml. And you can see that most women maintained virologic suppression across the subgroups. On the right-hand side, you will see in terms of age that a higher proportion of younger women maintained virologic suppression. The darker bar is at all follow-up visits, and the lighter purple is at the end of the study. Now, this is the slide among women who initiated with viral loads greater or equal to 50 copies per ml. And most of the women here, as you can see across the board, across the subgroups, achieved virologic suppression. But when it came to BMI, you can see a higher proportion of women with a BMI greater than 30 compared to those with a BMI less than 30 that achieved virologic suppression, less than 50. Now, this is the best slide. So we want to try to really digest and explain this slide because there's a lot of subgroups and numbers, but of the 532 women, 464 had data on at least one viral load number. And those 464, 372 had initiated with a viral load less than 50 copies per ml. And from that group, 5 had confirmed virologic failures, corresponding to 1.3%. Again, going back out of the 464 who had at least one viral load on follow-up, 92 initiated with a viral load of 50 or more copies per ml. And of those, we saw 2 confirmed virologic failures corresponding to 2.2%. So the real-world study this is a real-world study of 532 women who received CAB, rilpivirine long-acting, had notable diversity in patient characteristics, and over 2/3 of the women were Black, and about half had a BMI greater than 30 at initiation of the injections. Despite some differences in outcomes based on race, BMI, age, CAB, rilpivirine LA demonstrated high effectiveness sustained over time. The strengths of the study is that, to our knowledge, this is one of the largest real-world evidence studies of women on CAB, rilpivirine long-acting. It did have a diverse representation of women with HIV in the United States, and it described real-world data, what's happening in the real world in different organizations across the United States. Limitations, we had oral bridging does happen. That was not well documented in electronic health records, and neither were the reasons for discontinuation. I do believe, and we strongly believe, that additional research is needed because this was a medium follow-up of 12 months, and we need additional research with a longer follow-up period to allow us to include more women in order to power subgroup analysis, in order to have regression models to assess predictors of confirmed virologic failure. And our take-home messages, we had this real-world study of over 500 women in the ABRA cohort, notable diversity across age, gender, race, ethnicity, and other characteristics. CAB, rilpivirine long-acting demonstrated high effectiveness sustained over time. Confirmed virologic failure among women was rare, which is consistent with what we see in other cohorts, and there were no subgroups with consistently better or worse outcomes. I want to take the time to thank, we have a women's initiative that we started at Epividian, trying to develop more studies around women by women. And I want to thank my co-authors. I want to thank patients, women living with HIV, their healthcare providers, and the rest of the team at Epividian. And thank you for inviting me.